Good morning. Good morning. I think we'll get started with introductions. It's 8 o'clock. Welcome everyone, and hope everyone is well. So I think we'll just start with introductions. That always takes quite a bit of time as we're waiting for others to come. A whole packed program, and for everyone's benefit, we intend to make this extremely interactive. So very few presentations. It's a new topic for most of us. So let's engage. Please ask questions. We've got colleagues online as well. I understand there are about 40 people online. So they'll also introduce themselves, maybe just by typing their names, their organizations, and the third thing that we want to hear is what you expect to get out of today's session. So once again, please tell us your name, the organization you're representing, or if you're representing yourself, that's fine as well. What you expect to get out of today, and then we'll engage as we go along. So I'll start with this gentleman here.
Thank you. Good morning. I'm Sadiq Rashid from AMREF, Health Africa. My expectation is just to learn more about the SMART guidelines and to see how we can incorporate them in our digital tools. Thank you.
Good morning, ladies and gentlemen. Good morning. Good morning. Oh, we don't reply greetings in the morning. My name is Nancy Amayo. I work for MOH, Division of Digital Health and Health Informatics. And my expectation is just to understand our role as MOH in ensuring that we proceed or succeed with the SMART guidelines. Thank you.
Good morning, everybody. My name is Gilbert Nsomo, working for MOH, Division of Health Informatics. And I'm really glad to be here, basically to touch base on the development on the SMART guidelines, and to what extent are we actually adapting. Thank you.
Good morning. My name is Caroline Kamoshe. I work for MTIBA, KPA. My expectation is to hear more about the SMART guidelines and the implementation thereof in our country. Yeah. Oh, sorry.
No problem. Good morning. My name is Deuri Muni from Mater Hospital. I want to understand the SMART guidelines, and as usual, Steve always surprises me with new things, so I'm here to learn from Steve as well.
Yeah, good morning. I'm Dr. Ayub Manya from the Ministry of Health in Health Informatics. I wouldn't say I'm representing anybody, but I'm interested in these digital things. I think I've been in this train for too long, and sometimes it leaves me, and sometimes I catch it up. So I'm together to see where it takes us. Thank you.
Good morning. I'm Elizabeth Wamwe from the Karen Hospital. Technology being a key pillar of healthcare, I guess it's for us to learn more and see where we are headed to and how we can use it more in healthcare. Asante.
Good morning, everyone. I'm Pauline Omoto from the Kenya Legal and Ethical Issues Network. My expectation is very similar to everyone else. I just want to learn more about this.
Good morning, everybody. How are you? Let me ask what Nancy asked. You're not answering greetings in the morning. Habari zenu? Good. I'm Dr. Beatrice Kariuki. I'm representing myself, as well as Health Code Network, as well as KHIA. Can you see that paper on your desk? KHIA, make sure you look at it. My expectations for today's meeting is just to interact with you as you interact with the SMART guidelines and hear your thoughts on them. Thank you.
Good morning, everyone. My name is Njuguna. I'm a product manager in Safaricom PLC. I'm basically here to understand the SMART guidelines and the implementation. Thank you.
Good morning, everyone. My name is Dr. Ngure Nyaga, here for Savannah Informatics and also K here. And I'm hoping to see the COP come to life, an actual community.
Good morning. My name is Beryl Kanali. I'm representing myself. I'm here to understand the SMART guidelines and how they're being adapted across different organizations.
Good morning. My name is Faith Chepkoech from APHL, representing APHL also. I'm here to understand about the SMART guidelines and the implementation. Thank you.
Hi, I'm Chris Ihure from Farm Access. Our interest here is to learn more about the SMART guidelines and see what role we can play in assisting in the implementation.
Good morning, colleagues. My name is Duncan Chege. I work for ICAP. I think this meeting couldn't have come at a better time. We are at the throes of really developing systems that will work at the Ministry of Health, and we all need to speak the same language. And these guidelines, I think, are the key to that. So we are building systems for the future, and we all need to be speaking the same language if we are pulling in the same direction, or if these systems need to go past the typical lifespan of 2 or 3 years. So this is a very, very important meeting for us. Thank you.
Hi everyone, good morning. My name is Sylvia Mwalu from Kenya Health Informatics Association. Yes, as Beatrice said, please look at this and scan it and sign up. So I'm here to learn more about the SMART guidelines and their implementation. Thanks.
Hi everyone, good morning. My name is Mwindo Brian. At Intellisoft, I represent the quality assurance engineering. I'm here to learn about SMART guidelines, and also I'll be providing some support for the same. Thank you.
Good morning, everyone. How are you today? My name is Irene Maitha, a project manager at Intellisoft. Welcome to this meeting.
Good morning, everyone. My name is Leslie Gidinji, work for Living Goods, the digital health manager. I'm here to learn more about the smart health guidelines and see how we can continue plugging in.
Good morning, all. My name is Daniel Chalal, representing the National Nurses Association of Kenya. My objective here is to learn about guidelines and how it can make us to work smart and network. Thank you.
Good morning. Emmanuel Kweyu from Strathmore University, here to learn about the SMART guidelines.
Good morning. Daniel Maangi, I work with CDC, here to learn more about SMART guidelines. Thank you.
Good morning, everyone. My name is Jacob Odiapo. I work for Palladium. I'm here to help informing the community and to hear what others are doing on this space.
Good morning, everyone. My name is Dr. Jean Kula. I work at Helium Health. I'm also here in the capacity of Vice Chair of the Digital Health Committee for Kenya Healthcare Federation, here to learn about how we can support our members in the implementation of the SMART guidelines.
Good morning. Jay Patel from Jacaranda Health, learning more about the SMART guidelines, how to implement them, and also the community practice.
Good morning, everyone. My name is Nelly Nyaga. I work with Intellisoft. We've been working with the SMART guidelines for 1.5 years now, and I'm really excited to be creating this community of practice with you all today, and looking forward to what we can do together and see how we use the SMART guidelines to advance tech and health in Kenya. Thanks.
Good morning. Good morning once more. My name is Samuel Kanga from Medtronic Labs, and we are here to support the community of practice and contribute to the initiative of the SMART guidelines as well as implement them. Thank you.
Good morning, everyone. I'm Margaret Ndisha. I work at Path Digital Square, and I'm here to understand my role of making this community of practice vibrant. I think we need to get it going. Thanks.
Good morning, everyone. My name is Mandela Kibiriti, medical doctor, collaborator with IntelliSoft on the SMART guidelines as well. Looking forward to learn from everyone, and also to participate in the community.
Morning, everyone. My name is Benjamin from Honor Systems. We've implemented SMART guidelines for a while with WHO. So I'm excited to see all of you here and looking forward to building this community.
Good morning, everyone. I was hoping to just hide in the background, but Steve caught me. My name is Dr. Samira, and I am the lead for the medical team at Maidawa, and I'm happy to learn from all of you here today. So thank you for the invite.
All right, thank you, everyone. And we've got many more colleagues online as well who introduce themselves. I don't think we'll have the time to have them speak, but I think they're about, what, 40? Yeah, I've got about 40 plus people. Yeah, 42. So I think we're doing well time-wise. So as we wait for Dr. Ryan Nyotu we are aligned in terms of why we're here. Most of us want to learn, which is, I guess it's a never-ending process. SMART guidelines is fairly new. I think as you've heard, even for some of us who've been part of the process for a while. So we learn from each other what we don't know. We are also very fortunate to have a session at 10 o'clock. If you look at your program, we'll be hearing from Nat from WHO headquarters in Geneva. She's one of the people who's in the Department of Digital Health and Innovation in WHO and has been involved in SMART guidelines right from the beginning. So she'll make a presentation. SMART guidelines is a WHO creation. So we need to hear from the creators what they had in mind when they created SMART guidelines. But for those of you who work with WHO, as you know how it works through member states, countries like Kenya are at the forefront of adopting SMART guidelines. Fortunately, we also have people here like Benjamin, Margaret, who else is here? Nelly, of course, Jacob, Dr. Jacob, who've actually implemented SMART guidelines. So we'll also hear some use cases. Honor is a technology development company. So they've literally transformed SMART guidelines into computable guidelines a lot. Dr. Ngure from Savannah Informatics as well has also done quite a bit of that work. So we've got people who have actually explored how do you use SMART guidelines practically in building digital health systems, and we'll hear from them. And yeah, so Margaret at Path is leading some work on adapting of SMART guidelines in immunization program. So we'll hear that, that experience. Dr. Jacob from Palladium, they're leading some work together with IntelliSoft on SMART guidelines in HIV. Dr. Ngure has worked for a long time in social health insurance and how do you adapt these technologies and the basis for this, like SMART guidelines in that area of healthcare. So we'll get to hear a lot of these sorts of examples. But also, I'd like to encourage everyone, when Nat presents at 10, please ask her questions. She's representing the expert of experts about SMART guidelines as the primary authors of SMART guidelines. So please, let's engage with her at 10. She'll also be able to share with us the thinking by WHO, currently where the SMART guidelines are at, and what they're envisaging moving forward. So I also just want to mention that we have, fortunate with us, we have Daniel Mangi from USCDC, who are also sponsoring a lot of the work. So they're a major supporter of Ministry of Health, a long-time partner, and they're the ones who are supporting the work that Palladium and IntelliSoft are doing on HIV, strengthening HIV program using SMART guideline. So we'll also get to hear from Daniel about how that is going. And then we'll lastly conclude through a session that Nelly will lead on the current thinking around the community of practice. I don't know how many of us have been part of community of practice, but this is a community by definition. So the thing that we'll probably be talking about at that session is how does this community not end here? How do we ensure that once we leave this hotel, we can continue collaborating and engaging towards common goals? So we need to define what the common goals are. We need to define methods, mechanisms, tools of engagement and collaboration. And then we need to engage to also agree what do we want to prioritize and work on. So when Dr. Ryan comes, he's going to tell us from the ministry perspective, what has the ministry prioritized in terms of smart guidelines as part of the digital health superhighway. So again, ministry is very clear what they want to do in digital health in Kenya. So I hope each one of us can also say what you want to do for your organization. Some of us come from private health sector, some are in public health sector as well, and some of us are in both sort of sectors. So this is a time for us to sort of share what is most important for you as you get to understand smart guidelines and you see where you can apply those in your organization mission and all that. Then we need to start building the priorities for this community. As we do that, we'll also be able to define how do we more effectively engage with WHO and others across the world who are working on this. So there's a huge movement on smart guidelines. Again, as I mentioned, even though it's fairly new, but there are many people who are actually working on smart guidelines globally. We had our first global, they call it smart ecosystem, that was hosted by WHO in Geneva last year. That was like the kickoff meeting early last year. And then we had another meeting in Cape Town that was hosted by Helena. And it's very likely that we'll have another community meeting end of this year, global meeting, hosted by Ministry of Health, Helena, Kehi, and others, when Kenya hosts the Global Digital Health Forum in December. So if you're not aware, please make notes of a very important meeting that will be hosted in Kenya called the Global Digital Health Forum from 4th to 6th of December. It's traditionally held in Washington, D.C. Every first week of December. It's the first time it's leaving the US, first time it's coming to Africa, first time it's coming to Kenya. So it's a big deal. And we'll host the smart guideline meeting within that broader meeting. So there's a lot going on. But I think just to, again, just level set why we're here is this is a sensitization meeting on smart guideline. So as you see the sessions we have there, some of them are just educative in nature. We also want to hear what approach and strategies the Ministry of Health has taken to adopt and adapt the use of smart guidelines in Kenya. So we'll hear from Dr. Nyotu once he gets here. And then, of course, create and operationalize this community of practice. So that's why we're here. Again, if you have any special interests, like I mentioned, we want to keep the presentations very, very short and make this very interactive. So please, let's talk. It's a community and we are all peers here. We've gotten a few colleagues who've joined us, so as he settles down, I will invite Gloria to introduce herself.
Good morning. My name is Gloria Tundi. I work for the University of Nairobi under the TAP project. Thank you.
Good morning, everyone. My name is Mary Burgami. I work for Logic, leading BD. Nice to meet you all.
Morning, everyone. My name is Roy Munge. I work at Honor Kenya, and I'm a solutions architect. Nice to meet you.
All right. So it's 8:30. I'm going to change a few things around, and I think I'll invite Nelly. She was supposed to go last, but I think it's okay for us to start because we're in sort of that mood of talking about the community. And then when Dr. Ryan comes, or maybe right after that, we'll hear from Daniel Mangi after Nelly.
Good morning. So I'll be talking about the community of practice and the thought behind it, and what objectives we have in mind, and we are open to some of your ideas, not some, all of your ideas around this. I'm just waiting for the pointer. All right. So first, it's going to be dubbed, or we have dubbed it, the Kenya Smart Guidelines Community of Practice. And I know a lot of us here are probably part of different communities within either digital health or global health or other other fields. And really, what we're going to be doing is just creating a place where we can share ideas, share knowledge, and hopefully hopefully advance the application of smart guidelines within Kenya. All right, and so this is the overall big goal or the dream, and it's to have smart guidelines as a foundational standard for the digital transformation of health in Kenya. I think we'll hear this, as we go along today, that now smart guidelines are actually being considered, as part of the digital infrastructure for healthcare. And as we go through the presentations today, we'll get to know how smart guidelines can actually, support the various digital interventions that we are working in, and how we can ensure that the digital solutions are standards-based and that they actually promote the application of the clinical guidelines and recommendations that have already been set, so that they actually promote evidence-based care. And so the objectives of this community of practice, as we have been thinking through it, so one is to advocate for the implementation of smart guidelines, which is part of what we are doing today. So really today is, it's part of the advocacy. We are calling together all stakeholders, trying to share, about what is being done globally, to get to hear what, colleagues locally are doing, and really position smart guidelines as an enabler of the digital transformation that we are looking towards. So that is one of the things that we hope, this community is going to do. Secondly is to facilitate the exchange of experiences and ideas. There's a lot that has been going on, even in this room, like Steve alluded to, and so it will be important for us to get to know, learn from each other, and see how we can use this to improve the ecosystem. Thirdly is to offer and spearhead capacity building initiatives around smart guidelines. There are things that are currently underway, thoughts around, can we have courses on smart guidelines, courses that maybe target, business analysts, courses that target software developers. So for instance, as a business analyst myself, what do I need to do, or what do I need to know about smart guidelines to be able to use them appropriately in my work? For developers and solutions architects, what do they need to know about smart guidelines to, to actually be able to architect, ideal solutions for healthcare? If it's about leaders, what do our leaders and policymakers need to know about smart guidelines? So really, we are looking at capacity building in those various pockets. And finally, it's to offer technical assistance. We know that currently there's a lot that is going on within Ministry of Health. We are aware that we now have a digital health agency, and there's a lot that is going on even to operationalize things like the Kenya Digital Health Superhighway. So as a community of people who will have knowledge and expertise on the smart guidelines, can we step up to offer and support, support ministry as they work towards operationalizing the digital transformation of health in Kenya? So those are some of the core objectives that we have set up, and we are happy to hear your thoughts on how we can maybe make this sharper. Is there something that you feel like we've left out and you feel like it will be an important part to include as part of this community? Right. So this was just an initial mapping of the key stakeholders, and I think we tried to cover a lot of the people, present in this room, and was the basis for even the invitations that were being sent out. So we are looking at the healthcare practitioners, and this is because, your medical doctors or your nurses or your clinical officers, these are the people who actually sit and support the development of clinical guidelines. These are the people who know that for HIV, this is the this is the regimen that should be given to, persons who maybe have HIV and TB, or the other people who, help us in crafting things like immunization guidelines. And we are looking at ensuring that these guidelines are eventually translated into the digital systems. And so that's why we thought that, these are critical people to actually have on the table. Implementing partners, who are represented in this room, you have Honor, you have Savannah, IntelliSoft, Palladium, all these people who are actually developing digital solutions. So we need them on the table because they're the ones who are actually developing these systems, and we need them to actually, be evidence-based, be based on clinical guidelines and recommendations. Then we have academia and research, which really is a no-brainer because this is where the action takes place, where, where digital health is taught, where we hope that smart guidelines could be incorporated as part of the training. Then we have funders and development partners who really are, give us the momentum and the resources to do a lot of the things that are done. And then the private sector, where we have a lot of digitization and a lot of, spearheading of the digital transformation that's already happening. So, and then at the bottom, the reason why we have these three is that, we are hoping that, or not hoping, that this community of practice is going to be anchored on Helena and Kehia. So Helena is currently, there's a lot of continental work going on within Helena. So Helena is the Health Informatics Association of Africa, and it is currently leading continental work on smart guidelines. And so Kehia is the local member, or the Kenyan association, which is a member of Helena. And so the smart guidelines community will be anchored on Kehia, but supported very closely by Helena. And the community of practice will also be very closely linked to the global work that is happening. So there is global community of practice that is anchored within WHO. So we anticipate to link a lot of the activities that we are doing with the work that is going on globally. Currently, there are a lot of standard operating procedures that have been developed by WHO on how we can actually translate smart guidelines. And so we are hoping to to adopt those approaches and use them to even guide the work of Kenya. Then finally, of course, the community will also be anchored on MOH and the Digital Health Agency, just because right, so I think I've alluded to this. So it will be hosted by Helena through Kehia at the continental level, and very closely linked to the work that is happening globally. So in terms of next steps after today, is one, we will have a call for membership. There is a registration form outside there at the registration desk, and there's also I've attached a QR code to this presentation. So we really welcome anyone who's willing to join and contribute and making this community vibrant, to really join, and we'll get to know and learn and share more as we go ahead, and even dictate how we want this community to operate. Then next is we're going to set up community of practice collaboration tools. We'll definitely have an online platform, our website, where we document everything openly and with every member, and everyone will be free to share their ideas on how we do better in some of the communities that you are part of. Then we will be having frequent community of practice meetings. So some will be virtual, others will be physical practice. Then more importantly is the fact that we will develop a community of practice roadmap. And this is going to be informed a lot by some of the key priority areas that ministry has selected. And I think Ryan will be maybe talking more about that. So ministry has some select use cases that are priority, some including the insurance, given all the changes that are happening within the social health insurance fund. We also have referral systems, and I think Ryan will talk about that. But yeah, the roadmap for the community of practice will be based on some of Ministry of Health's priority use cases. And then finally is that we hope to hold a side event at the GDHF later this year. So I think that's the summary of what I wanted to share. I'm not sure this QR code is going to be clear, but we'll share it at the end of the meeting, and even as we proceed, a clearer one. But there's also a registration form at the end, if you're at the door, if you're interested in joining the community. So I hope that as we go through this, the day and the meeting, we'll get to hear your ideas about how we can probably make this better. Yeah, thank you.
Thanks, Dr. Nelly. Once again, I think just for those of you who've joined us, so we've changed the program a little bit, just need to accommodate different schedules. So I know that was supposed to be the last presentation, but we started by at least explaining to you why you're here. You're here because we are establishing a community of practice, so I hope that helps to answer that question why we're here. I know you still have a gap of what is all this about, and that will be answered by Nat, not me. And that's the session coming at 10 o'clock. But right now, what we want to hear before before we get there, are there any questions for Nelly? Sorry. Are there any questions for Nelly, or is it still early? People are still processing. Okay, Beatrice. If you had an answer, I was going to call you.
It's okay. I'm just, for people who are very new in the space, just a clarification, what membership to the community of practice, is that different from membership to CAHIA? Like how do all those pieces that you've spoken about work so that people are clear what we're asking them to do? Thanks.
Great question, Dr. Beatrice. Yeah, so, and again, apologies that most of you probably haven't heard about CAHIA before today. So CAHIA is the Kenya Health Informatics Association. So CAHIA is a professional association for informaticians. Informaticians are not formally defined in Kenya, right? Who's an informatician here? We call ourselves everything and anything, isn't it? I can stand here and say I'm a digital health specialist. You won't challenge me, right? Yeah, so it's not formally defined, at least by government. But right now, just based on where government is going with the agency and all, I know there are plans by the ministry and other arms of government to start defining these categories. So there are plans, I think, to define what digital health means in Kenya, who's the digital health practitioner, who's the health informatician, and all that. So those definitions will come, and then once they come, they'll also define what does it take for you to become that kind of person. What training, what certification, and things like that, yeah? So it's obviously a fairly new profession, so a lot of things are evolving. But CAHIA, in short, represents informaticians, both in terms of formal training. Some of you are trained outside the country, and you're formal informaticians, by all manner of definition. But they're also enthusiasts. You're really interested in informatics, coming from healthcare. We've got a lot of medical doctors here, pharmacists, people from health sciences. We've got a lot of IT people here. People who studied computer science and IT and all that. We've got lawyers. We've got many people who are interested in application of technology and data in healthcare, right? Because that's a confluence of informatics, isn't it? So in Kenya, we're still trying to define that formally, but CAHIA basically represents those interests. So if you're that kind of person, and I believe you are, that's why you're here, then you're an informatician. Tusikizane, tusindio. Yeah. So in short, I think what Dr. Beatrice was saying, you're welcome to join CAHIA. And my colleague, Dr. Sylvia at the back there, she represents CAHIA, and she's happy to help you if you can just kindly fill in the forms that she's placed at the table. So that will make you a member of CAHIA. It's open. We're not very harsh on fees and all that, because it's still forming. It's been around for a while, but it's kind of still forming. So that's membership to CAHIA. So it's open. There are really no demands at all, honestly. It's just really enabling you to connect with people like those who are here and those who are not able to join us physically. Now, the SMART guideline is an entity within CAHIA. So you can think of it as a working group. So CAHIA has many working groups. We focus on many topical areas like standards and guidelines. So SMART guidelines is one of them. So CAHIA will be the secretariat of this community of practice, and CAHIA has many communities of practice. So again, depending on your interest, whether it's SMART guideline or it's SMART guidelines or standards and guidelines, if you're interested in HL7, fire, things like that, we've got all those sort of special interest groups within CAHIA. So you don't need to be a member of CAHIA if you don't want to be. You can actually also be a member of the community of practice. But of course, you're highly encouraged to join CAHIA because it really costs you nothing. I hope that answers the question. Any other question on community of practice? But maybe you can just proceed since Dr. Ryan is here. But before he gets ready, I know we've got a few people who joined us, and I'm looking. I just want to make sure that we hear everyone. Communities you're supposed to talk and hear each other's voice. I'll start here.
Good morning, everyone. My name is Silas Nyachai. I'm here representing Christian Health Association of Kenya. As a faith-based NGO supporting health facilities.
Thank you and welcome. And other.
Good morning. I am Dr. Radha Karnad, one of the founders and Chief Medical Officer at HealthX Africa, which is a primary healthcare telemedicine-based service. Thank you.
Morning, everyone. Richard from Strathmore University, part of the iLab Research and Innovation Center.
Good morning, everyone. My name is Tony Kariri. I work for Partners for Health and Development in Africa. I'm keen on this.
Great. I think please allow me to, at this point, just so we can manage time, we'll have plenty of time at the end of this all, to welcome Dr. Ryan Nyotu, the head of Division Digital Health at the Directorate of Digital Health, Informatics, Policy and Research. And he can tell us about how the ministry is thinking and approaching smart guidelines. Dr. Ryan.
Thank you, Steve. Good morning, everyone. Welcome to this meeting. Apologies for being late. Also, there's a team which is not here yet. They are currently in a meeting at MOH, and the director was here, but he'll be joining us soon. Welcome to this conversation. There'll be a presentation. I hope they're able to get it up and running. Today, we're here to talk about smart guidelines. It's important, even as we start this journey, for us to see and take note of where we are. And I'll begin by addressing the elephant in the room, that even if we are really talking about digitizing and the steps we're taking, there's still a lot of people who have doubts about whether we'll get there, about whether this is still all words. And this is really hampering the adoption of these ideas at the rate where we need to get. So some of these meetings are important for us to come and sit together and just talk about this. Just by a show of hands, I want to see who is hearing about smart guidelines for the first time here. Good. This is very good. So we won't do a lot of random introductions. So the government has taken its stance on how we are going to the government has taken its approach on how we are going to approach this entire UHC agenda, giving everyone quality healthcare regardless of where you are. There's a team which is deep into work working in human resources for healthcare. We've just seen how tumultuous that has been with a strike that has just ended a few weeks ago. We also have another team trying to address the health financing issues. We are seeing how tumultuous that is and how not easy it is to achieve all that. And there's also another team deep in the gutters working on finding a way to help us have commodity security. Because you want, when the patient comes to the facility, there is enough resources to pay for their care and to pay and to ensure that there is quality human resources for healthcare, and that there'll always be the commodities they require at the time they require. However, for all this to happen, data has to move. And for data has to move, we have to have found a way to standardize data. Because the challenge we've had in Kenya for a long time has not been a lack of technology. We have so many technologies, a lot of entities here are representing different types of point of care systems, different kinds of technologies being implemented in different kind of contexts in the country. That has not been the challenge. The challenge has never been a technical one. The challenge is a coordination one, and that is the government's role. So how do you approach the process of making this data clean so that it can move within the sector to allow for all the other three to be able to achieve what they need? So this is where we go back to our legislative documents that we are bound on, and this is the health, in order of hierarchy, the Constitution, then the Health Act of 2017, DPA, the Data Protection Act, then the Digital Health Act, then now the Cyber Security and Computer Misuse Act. These are the acts upon which we have this task of implementing the Comprehensive Integrated Digital Health Information System. So I will talk about this later. So I've talked about the fragmentation. So the approach and the duplication. I want to get to standards. Okay. So
this is an old picture of something I'm sure all of us have seen. And if you haven't seen this image, we need to have a conversation on the side. This is HIE. This is how the government has taken it. There've been many approaches to how you can do this. And we've been having engagements with different countries, even with different people. There are people whose approach is to implement one system in the whole country and have everyone use this system. And this has been tried out in different places. There are many places where many approaches where people have taken it in counties, like regional areas, where you have one system running in one region, but then that data is not able to move. And this is the approach a lot of the world is now going to. Vendor agnostic kind of system where interoperability is able to go through. So this is currently the work that is underway. Even the guys who are not here are currently in a meeting just to discuss the progress of the other parts. So that is the Kenya Client Registry, the Health Worker Registry, the Kenya Health Facility Registry, and the National Shared Health Record, all being served by what we call the Kenya National Health Terminology Service, where now inside we have the product, we have different services, you have the product catalog, you have the different code sets, and all the other things that you need. All of this become the core digital health information services. So what this means is we want to be able to, when a patient comes into the facility, we want to be able to identify who they are at the facility or even before they come to the facility. We want to be able to identify who saw them. We want to be able to identify the facility they were seen at, what quality of service are they allowed, what level of service are they allowed to offer. The community health unit registry, from where are you referring them from, or from where are you referring them back to as they go back. And then also through the shared services, we want to be able to understand exactly what was done. When we say what was done to them, if it was a drug which was given, the drug has to be referred to in one term. If it was a diagnosis which was made, it has to be uniquely identified also in one code that is identifiable across the entire sector. And then all of this has to shift to the National Shared Health Record, which is one of the routes we're looking at, how to make sure we control fraud within the claims management service. So what this means is this one will do. But then now here is where the gap comes in. We've implemented the standards, we've implemented the unique identifier registries. What is next? What's next is to have the point of care systems, which are on the left, starting to consume the resources. But once they consume the resources, will this be the complete picture, or will it solve the whole picture of what is happening? Yes, it will be able to help us to be able to help the data flow, but we need to also standardize how care is also being provided at the point of the facilities. If, for example, one doctor is treating a patient for malaria and another one is treating the same patient for malaria, they might use the same code sets, they might speak in the same language, but if the systems and how we're able to move our guidelines into how the system is to be used, we still have a challenge in trying to bridge the quality, the service quality bit. So the standards-based approach is now the model, and this is now the part we move into. This is now the difficult work. It is the one that allows us to see, yes, we've prepared the technology, then now let's take it to the healthcare system. Let's take care when we go to the ground, when we are doing services, let's start capturing what is needed for this. And so I'll speak about smart guidelines just shortly in terms through the eyes of the WHO structures. Just to talk about it. Just to give a feel about how it is. So smart guidelines are basically standard-based, machine-readable, adaptive, requirements-based, and testable. So it's a process by which we take the guidelines that are in physical form. For example, right now I can tell you if we went to Naivasha, we'll find a TB program or one of them reviewing one set of guidelines in one way or the other. There are a lot of guidelines that are available currently in different formats. How do we take these guidelines and convert them into a mode or codify them into a way that our standardized systems are all able to consume the same ones? So if my system is, if I'm running my own system and I'm seeing patients in a particular care? How do I ensure that my system is following the same guidelines that another system is going? How do we standardize that bit of care? This is the conversation we want to have, and it's an important conversation because we can't really look at all the other parts of standardizing and then leave that part out. So in terms of leadership and governance, in terms of leadership and governance, the government is very keen, and leadership is very keen on controlling this component. One of the steps has been taken, and you'll mention, you see even in some of the laws, SMITE guidelines are referenced, and they are mentioned. Because well, we want to try, and we've said the problem is a coordination problem. And then we allow that every person who is developing a POC or a point of care system to implement their own guidelines will, at one point or the other, will end up in the same situation of having very clean data, but we won't be able to compare it in terms of how well are people adhering to this treatment. If we're trying to control costs, if you're trying to control different things, you need a way to follow and say, did this healthcare worker follow the guidelines that are set about by law? And this is where we also get to bring in the end user. In this room, I would be curious to know how many, for example, practicing medical doctors we have, or nurses we have. We have to now finally start bringing them into the conversation, because even if we're building these systems, we're building these systems for consumption and utilization and ownership by them. Then in terms of, I will skip the strategy and investment bit, because that is now the conversation we're having. By building a community, we'll be able to mobilize resources to enable us with this work. Because if we imagine the number of diagnoses out there, the number of guidelines that really don't exist, I think we have guidelines for less conditions than we do. I think there are less, I think most conditions in Kenya that we're currently seeing, even under the general packages, most of them don't have guidelines. So the journey is going to be a long one, and it's going to be an exciting one. So in terms of legislation and policy, I've already spoken about, this is how we've already anchored it in, it's already anchored in law, it's already spoken about in some of the regulations, even some of the policies around also speak about the smart guidelines approach, but we won't lock ourselves to smart guidelines. Smart guidelines is going to be how we begin the conversation. Let me just give an example of how smart guidelines work. Like if, for example, we developed a smart guideline, let's say for vaccination, all I would have to do if I'm developing my system is ensure that my system is able to consume those smart guidelines. That would mean I wouldn't have to write code, I would want to write logic telling that if this patient presents with this, do this. If they don't do this, do this. Someone else can be developing that on the parallel track, and then other teams can focus on just developing the POCs to consume from the shared service. In terms of workforce, there needs to be a lot of work that we need to do in terms of smart guidelines. This community has to start moving very fast, because we have to start training people, and we'll need teams at all different types of levels. And smart guidelines will be developed moving forward and moving backwards. What do I mean by moving forward? There's some smart guidelines which will go all the way from raw guidelines in paper format to the digitized code sets through the IG phases, and there are some will develop from the system, just seeing what are some of the people doing, how are they doing, that go from the system use case going all the way back to providing guidelines that can be published in terms of paper. But this will be a lot of work, and this is something which I hope all of us will join early, learn what they are, identify the skill set. It takes quite a time to develop, for example, one implementation guide for one guideline, and to make it available for any type of system. But the hope we have, and the hope we have for Kenya and for the point of care systems in Kenya, is that they're going to be standardized. When you're coming into this country as part of the certification framework, you should be able to show us, is my system able to consume from the client registry? Demonstrate this. Is it able to consume from the facility registry? Demonstrate this. Is it able to consume from the shared services? This is good. Is it able to identify uniquely the healthcare worker? This is good. And is it using, and is it consuming and following the guidelines as described by government? Because there is no point of people working so hard to develop guidelines if when the healthcare worker is using the digital systems, they can decide to do whatever they want to do in however they want to do, and there's no way for the systems to capture this particular hospital. Patients are staying for 10 days longer. The patients are staying for 5 days longer. People are being given this test before this drug. And it's because, and when you go to discover and investigate how that is, you discover the gap is on the side of the technology, on the technology designers and the technology implementers. So finally, I want to thank Helena and WHO for taking leadership in this. We've had quite a bit of work. There is quite a bit of capacity locally already in terms of development of smart guidelines. And this is something I hope we can catch on for sooner. So I can see, for example, I can see USAID and CDC are here. I'm very excited. This is, for example, for Kenya EMR. I expect Kenya EMR to be one of the early systems that's able to now start consuming and utilizing smart guidelines and supporting in its development. I also expected the other teams to be here, but I guess they'll join us in a bit. Thank you. I don't know if I'll take questions.
Thank you, Dr. Ryan. Before we take questions, I just want to summarize what I heard from Dr. Ryan. For those of you who are listening, so what is the government's position on smart guidelines? The ministry. If you are listening. Tulisema tunaongea. We said this is interactive, yeah? So Dr. Ryan was representing Ministry of Health in terms of ministry's agenda on smart guidelines. What did you hear is the ministry's position on smart guidelines? It's not negotiable. Ama nimesikia vibaya? How many of you have read the Digital Health Act? If you haven't read, please read. Yeah, please read. It's really, really important to read the Digital Health Act because, as Dr. Nyoto has mentioned, it actually calls out smart guidelines from a perspective of, it's not really punitive, so I think we need to look at this positively. It's from a perspective of quality of care. So again, as we'll get to understand what smart guidelines are shortly, especially once we get to the session to listen from WHO, the rationale for smart guidelines is really around, first and foremost, standardizing care. Because if you've had a chance to look at smart guidelines, the first level is the narrative, isn't it? The narrative guidelines, which is, we're all used to the narrative guidelines that are published through WHO at the global level, and then countries adapt them, isn't it? And these narrative guidelines come from clinical trials, right? So that's the first level of smart guidelines. So there is a very strong basis of science in smart guidelines in terms of promoting standard of care. So in other words, the smart guidelines for HIV standardize how HIV care is provided. So even forget about technology for a minute. That's what smart guidelines do, right? They basically base everything on the clinical guidelines for that specific care service area. So if it's HIV, if it's malaria, if it's whatever you describe it, yeah, primary health and all that, they have guidelines, don't they? Is that strange to us? It's not, right? So if you look at the smart guidelines framework, that is L1, right? That's the foundational level for smart guidelines. Now, the reason why smart guidelines were developed by WHO is how do you move from those paper-based guidelines, narrative guidelines, to computable guidelines? How many of you have done requirements gathering, analysis, and all that when you're building systems? And how complex is it, and how many times do you get it wrong? And how many times are you told by medical doctors who are here, this is not how you do care? Cindy? We get that all the time, right? So the attempt by smart guidelines is to help that transition from how do you define and determine guidelines in terms of how healthcare is provided in a very specific health area or even broadly, and then how do you move that to build systems? So that transition has always been problematic, and so smart guidelines are trying to solve that problem first and foremost, right? If you're working within immunization, HIV, ANC, and all that, we do this all the time, and we don't always get it right. So the aspect of standards, which is the first S, again, I'll ask a question. What does SMART stand for? S is for? Standards-based, right? A? Msiangalie Google. A? Adaptive, right? M, I skipped M. M? Machine-readable, right? A is for adaptive. R? R, people are whispering. R, requirements based, right? T, testable, right? So again, we'll hear why all those letters are important, yeah? But you can already start to see why they're called SMART guidelines, right? So there's nothing really new. The SMART is really because you're transitioning from paper-based to digital. And how do you do that in a way that maintains the fidelity to the science of healthcare and service delivery? Okay. Questions for Dr. Ryan. So I was just summarizing what I heard from Dr. Ryan is that SMART guidelines are now formally adopted by Ministry of Health. They are also in law. So please read the Digital Health Act. Ministry is going to publish the regulations to operationalize the act. SMART guidelines are there. Then thirdly, Dr. Ryan mentioned something called certification framework. So the ministry is rolling out a certification framework to basically elevate the standards of the technology applications we are building in Kenya and using, right? So by doing that, through the certification framework, they're basically going to test your systems against standards such as SMART guidelines. So the earlier you embrace this complex topic, the better. It's in your best interest. So at some point, there will be no negotiation. Right now, I think there's plenty of time for us to talk about this, figure out how do we help each other, how do we get off the blocks as quickly as possible and start complying. And SMART guideline is one of the major ways to achieve compliance. So before I invite questions, let me just invite a few colleagues who've joined us, starting with Anthony. Name and where you're from.
Good morning. I'm Anthony Ojuang. I work with Palladium. Thanks.
Right.
Good morning. My name is Dennis Atandi. I'm working with KCCB.
Good morning. My name is Janet Nzai. I work for KCCB.
If I miss you, please show me your hand.
Good.
Good morning. Simon Bai with Medic.
Good morning, everyone. My name is Lois Kurisha from IntraHealth International.
All right. Questions for Dr. Ryan or for Ministry of... We've got several MOH colleagues here. Do you have any questions for Dr. Ryan? Yes, some.
Thank you, Doc, for that presentation. I think my question goes to, in this dispensation of the primary health care, so there are a number of health areas that still don't have SMART guidelines. Mine was, what's the approach that the MOH is taking in terms of ensuring that all these areas have the SMART guidelines developed to guide implementers? Thank you.
Okay. I think that's what I said in the session. Majority of areas don't have SMART guidelines. So we need to go towards a model where we can adopt, we can have a guideline types of guidelines that systems can consume. So the approach is first to identify a modality we can use, and that is now the SMART guidelines that we have selected. Then now the phase we're in is building the community. A lot of the people here are the early adapters. A lot of the people here are the people who are going to work with together to develop the different areas that may be there. So your question for me is an opportunity for everyone in terms of the earlier you identify an area that has no that you can work in, the better, and that will be what this community is all about.
Thanks, Dr. Ryan. And I think just to add to, before I come to you, Dr. Beatrice, so just to add to Sam's question, so the way it's currently envisaged, and Dr. Ryan has provided that as an opportunity, there's definitely a bottleneck. And these are questions that I'd also request that you ask Nat from WHO when she presents. So the way it's envisaged to work is WHO is not disrupting how this works. So basically the way it works, or at least the way I understand it works, is if there's a new health area that people don't know about, as an example, when COVID broke out, there were no guidelines for COVID, were there? So the world had to very rapidly develop guidelines for how do you treat COVID-like symptoms, isn't it? They didn't even know what COVID was, right? So the scientists, some of you who are here, grappled really quickly to define what is COVID, first and foremost. It was a set of syndromes and all that. How do you diagnose COVID and how do you treat it, isn't it? And then out of that, they rapidly developed guidelines. Who saw COVID guidelines from WHO? Cindy, I mean, because at that point it was an outbreak, everyone was treating these things differently, isn't it? Now, standard of care means what? That we are standardizing care, right? Now, that whole process of how do you define what is this thing we're dealing with? Do we understand it enough? Can we diagnose it, and then can we treat it and contain it? Then once that is done through clinical trials, then they develop guidelines and say, we understand what this thing is we're dealing with, and this is how you deal with it. This is how you provide services, right? So that took a while, but of course, because it was an emergency situation, they did that really rapidly, but that's been revised a few times. So the question that Sam is asking is, we don't have guidelines for every health condition or every health threat known to humans, isn't it? There are some that don't have. Yet, smart guidelines, the way it's being framed right now, is that it comes from once WHO defines the global guidelines for a certain specific area, then their member states, which Kenya is one of them, take that guideline and then domesticate it, isn't it? Because the situations in Kenya are not the same as Europe. So the Ministry of Health takes those global guidelines and they domesticate. And that's what has happened for most of the diseases, both communicable and uncommunicable diseases. And then once you have those guidelines which are formal, then now we go to the rest of the layers of the SMART guideline. And now we start developing the systems out of that and all that. So the question that Sam is asking, not every health condition has a foundational clinical guideline. So that's the discussion that is currently ongoing. And it's one of a logistics question and all that, because the whole basis of SMART guidelines is the science around the clinical narrative guideline. So if you don't have that yet, that is approved by an authority like WHO or an authority like Ministry of Health, then how do you proceed? So that's the discussion that I think, again, I encourage everyone to ask WHO once they come online at 10 o'clock. But let me go to Beatrice, then I come to Jean.
Sorry, I have to represent clinicians in the room and everywhere. From like many of the studies, and I know there is one that Ministry of Health is about to take out a survey on quality of care, clinical care. Perfect, we're at the level of guidelines. I know this is a system team, but I'm bringing this on the table for thought and discussion, Dr. Ryan. So we find the guidelines exist, but the percentage of health workers who've seen them is very, very little, yeah? Most of the guidelines in the different areas are very, they are scarce. Can I call it that, yeah? They are scarce. So I think we need to also factor in systems of dissemination or massive training. Otherwise, the backlash will be on the system of the, you know how you get a system that's forcing you to do something that you don't usually do, like e-citizen, right? Yeah. So you keep saying, this thing, I can't renew my license. What's wrong with it? I can't get it, yeah? So your backlash is on the system, but the gap is actually in the knowledge of the health worker about that guideline. So they've been, as we usually say, they've been practicing witchcraft, yeah? But you're trying to get them to a higher standard, which they don't even know about. Dr. Ratha, I know we've been on health techs, CME, where we're talking about antenatal care. People are not sure which version of the guideline are we talking about. Are we picking this piece from 2018? Is it 2022? Or this was revised? So how do we consider that dissemination changes that this will require and bringing the professionals up to speed, maybe through the organizations or whichever the other avenues? Thanks.
Thanks. You had briefly mentioned about capacity building. I'm just thinking how the ministry is thinking through that, actually disseminating it through. And it might be that these are some of the discussions that we're having. Are there some use cases that you've seen how WHO has carried out in other member states? Since it's going to be like a non-negotiable, are we thinking of embedding it into curriculums? And for those already in practice, how will that be distilled down?
Okay. Thanks. I'll begin with Jean's question. That one is way, way harder. Because how are we thinking in terms of capacity building? For now, we are in the sensitization phase. For now, we are starting the conversation. Smart guidelines is a conversation which will take us a while. So step one is identify. We've worked and I've identified and I've interacted with a lot of the organizations who have guidelines capacity. So first is to bring them into a community, develop the idea of who are the people who are going to need this. So for example, as we go out to do the certification conversations, you will hear a lot about smart guidelines, and then we'll also work with WHO to see how now this training can be onboarded. There's also a lot of work to develop and see what capacity is there in different organizations, and here I'm really putting a line between the tech side and the clinical and the clinicians and the clinician side, because we need capacity to develop on both sides, on both of the sides. So this one is something where this is part of the early work to develop the structure of how we are going to start doing the capacity building processes. We've engaged with quite a few different types of. We've had different conversations in terms of how to also resource mobilize for this. A lot of the financing, a lot of the things that are coming in. For example, we are putting a conversation. We are putting this as a conversation there. We're putting this as a conversation there. Then, thank you, Dr. Beatrice. This is the truth. Majority of us in clinical practice, you practice what is practiced in your facility. So if you have 15,000 facilities, we may have 15,000 different ways of treating different conditions, and this is a challenge. And when we talk of the digital superhighway, the digital superhighway has value. It's not something which is being pushed by the government. It is something which, as we move into the adoption phase, we have to make sure we focus more on what is a value proposition to everyone. So, for example, to the regulators, this is, for example, who is going to be regulating quality. Quality is going to be either handled between three entities. That is the people who regulate the healthcare workers, KHPOA, and the quality authority, which is coming. By the time they're coming in, we want them to find mechanisms already there. So in terms of deciding to approve which guidelines are going to be used, what is being done, this is going to be something which is going to be, the digital superhighway is going to be a value proposition for them, something for them to adopt. When we come to the different associations in a lot, if you attend their meetings, and we've been interacting with some of them, interacted with the pediatricians, we've interacted with the surgeons in different conversations. There's a conversation about how do we ensure that everyone follows what we are saying. And like everything else in this conversation for UHC, when people get to that wall of how do we enforce, they always say digital. So we have to, on our side, we have to sit and think, how does this become reality? And I just want to give a simple brief. For example, in the current requirements for the systems that are going to be rolled out is something which today people are calling AI. But I guess in the future it will just be regular and utilizable across systems, and this is clinical decision support systems. A lot of systems are also already starting to develop their CDS, their clinical decision support systems. So this is one of the things, even as part of the digital superhighway, we've already started developing the hooks as to where the clinical decision support system will be able to come and trigger different parts. For example, in terms of dispensation of drugs, we'll have a drug utilization review system. So for example, if my shared health record says I have this type of side effect, before that drug is dispensed to me, the digital superhighway should, either through your patient portal or through different mechanisms, alert you that this drug you've been told to buy by that doctor is not a drug you should touch for now. Please consult, please go and reconsult the doctor. On the other side, for the doctor will also get a will also get a notification that you have prescribed this to this particular patient and this patient has this type of side effect. For that kind of system to work, for that kind of system to function, we really require to have a middle ground, which is now where we are coming in. So in terms of dissemination, again, dissemination we'll do massive campaigns through the associations to tell them that we are coming to support you in converting your guidelines. But even the why for why adopt smart guidelines for them will be, this is also a mechanism for you to enforce. This means that if a system is consuming the smart guidelines and you've given this, you've identified this as a presenting condition, and then you've identified this as a differentials, you've given this as a definitive diagnosis, and then you order a lab test that is not part of the approved guidelines, the system is supposed to be able to pick that up for you. And this is also how we are going to try and gently just push the sector towards following standardized sets of guidelines. But also at the same time, we also need this to be led by the associations themselves. We also need this to be led by the people who are offering services. So for us, it's about how do we also now start bringing in that side into the conversation very, 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 very early. I think those are all the questions. I think we can proceed because of time.
Thanks, Dr. Ryan. I know there are probably still questions that have not been answered, but allow me to maybe also invite one of the main partners of Ministry of Health, the US government through the US CDC, Centers for Disease Control and Prevention, represented by Daniel, and also one of other very important partners in Kenya, Palladium, represented by Dr. Jacob, to share with us one of the ways that public health is actually utilizing smart guidelines. I think as we start understanding, continue understanding smart guidelines, it might also be helpful to understand, is this just a theory or is it being used anywhere? So maybe that will also help answer a lot of the unasked questions yet. So I'll invite Daniel and Dr. Jacob, have about 30 minutes to share with us a practical application of smart guidelines in Kenya.
Good morning, everybody. Yeah, thanks for inviting us to this breakfast meeting. Looking at the back, I can confirm it's indeed a breakfast meeting. Yeah, so Kimanga is away attending a CoP meeting. And then also Sashi, had other personal issues, so she had to travel. So this is an important meeting. As CDC, we are taking it seriously. And I mean, when Ryan said that he was asking, whether all of us have heard of smart guidelines or not, I realized nobody is raising a hand. So it means that we are moving into implementation. So for that reason, I want to invite Dr. Jacob to just give us a highlight of what we are doing in terms of smart guidelines.
Good morning, everyone. Yeah, so my name is Jacob, as has been said. I'm the director of a project called Kenya HMIS. But for this presentation, I'll be talking about work that has been funded through CDC. Just to, first of all, just acknowledge that collaboration among other partners. I think we're also having ITEC among other partners. So I'll just start by giving a brief overview of, a brief highlight of, a brief overview of the work that we are doing, and then context, and then we talk about indicators that we are working on, and then the next steps. So I just want to give a brief background. So we have been working in the HIV space for a while, and just going through the clinical guidelines for HIV yesterday, it has 59 pages. That is just one program area, and that does not include the reporting component of how you are supposed to report services in the HIV space. Well, and even for this is just for the HIV treatment. So HIV has several guidelines. There are guidelines for HIV prevention that guide providers on what we call combination prevention interventions. How do you combine abstinence with condoms, with pre-exposure prophylaxis, post-exposure prophylaxis to take care of a patient, isn't it? Then when you go to the facility and you are tested, that test is based on a clinical guideline, right? Then if someone turns HIV positive, then there's a guideline that guides you on how to take care of that patient. So when Dr. Ryan was talking about the process of adoption of guidelines, you can imagine now the breadth of guidelines that we are just talking about, right? And I've talked about the reporting guidelines. Then there are guidelines for disease surveillance, for HIV specifically. So the breadth of the guidelines is very, very broad. Now, to remember all these guidelines, your typical level 2 has like just two providers who at the end of the month they sit together and count the registers to find the total services. They offer prevention services, they offer malaria. So this one healthcare provider, even if you train them, they have so many guidelines to remember that sometimes it's impractical. And then when you combine that with guidelines being replaced every 3 years, then you end up with a provider who is basically overwhelmed by just guidelines. So what is the process through which guidelines are adopted? That brings another complexity. So WHO comes up with these guidelines. Then in Kenya, and as for specific HIV, the WHO guidelines are based on a lot of research, and I think Steve mentioned about that. But then in Kenya, we combine that research with implementation science. Kwa ground, ground is different. Sindio? Yeah, the status of our HIV epidemic is different. So we actually customize those guidelines to Kenya's context. Then now comes in Anthony here, who is a software engineer. Together with the requirements gathering team, they come and now translate that into workflows in the EMR, so that a provider is guided within the EMR. How do you now conduct an HIV test and record the service? How do you enroll a patient to HIV care? How do you treat that patient? Which regimen do you give them? When you're changing a regimen, how do you do it? And the EMR becomes now a tool that actually helps that provider to navigate the complexity of the guidelines. Okay? But now the problem comes in, and I'll be illustrating the problems as we go along, because in the HIV sector for a long time, we had so many EMRs. How do you assure that the person who is doing in AMPAT, who is developing an AMRS, the person who is developing Kenya EMR, is implementing the clinical guidelines for HIV the same way in their EMRs, right? So there has to be a place where the developers who have been reading the paper guidelines, translating them into systems, can be assisted to make this process a bit easier. And I think that's where the smart guidelines come in, right? Then there's the healthcare worker. When you build these workflows in the EMR, when you build the reporting logic in the EMR, the provider who used to count the numbers in the register can now be assured that when they generate the report, it's in line with the Ministry of Health's guidelines. And then, of course, focusing on person-centered care, these differentiated models of care that require that you offer services that is a bit more precise to a person's health circumstance. These can actually be standardized using the smart guidelines. So just moving forward to the next slide. I think this one has been said before, so I don't want to spend so much time on this. I'll just go briefly into a bit of where we have been and where our interventions have been focused on. I know when you're presenting, when the WHO is here, I probably will say something that they won't agree with, so I don't want to focus on this slide. I think Steve also mentioned it earlier. We can go to the next one. So what have we been doing? So as I mentioned earlier, we have, when I used to practice, I used to have one in my pocket, okay? One in my pocket in my lab coat and another one on the desk, so that when you are now doing a pediatric clinic, unafungua kwa guideline unakasoma, right? But now, the developers like Anthony, who are not healthcare providers, I think the other day I saw them struggling with something called aliquots in the lab. They need to interpret these things so that they can be able to come up with software. Cynthia? And I think this is where now the process of writing down your requirements is now being done in a standardized manner so that their work is made easier, right? Then when you reach this level, it's about providing them with the code already standardized so that then they just adapt it in the EMR systems as they build them. And I'm just focusing on the EMR. So what have we done? This is just the same representation, the narrative guidelines, the digital adaptation kits, which I hope WHO will talk about, and then the machine-readable recommendation. So these three levels is the level at which we have been operating. As I mentioned earlier, for a long time, we have been looking at the narrative guidelines. Now, recently, for a part of the HIV clinical guidelines, together with the team that I spoke about earlier, they are translating these guidelines into a digital adaptation kit. What documents we had previously for computing certain indicators in the HIV space, and the other level at which we are operating is developing, together with the WHO, the machine-readable recommendations and adapting them into Kenya's context. So basically, in summary, I'll be talking more about the 3 areas, the WHO SMART guidelines. So I'll skip this slide. The country normally monitors how many patients are actively taking ARVs. Currently, Kenya has around 1.2 million people taking ARVs, and it's how many people are accessing HIV testing. This is important because it helps us to quantify how many commodities we need to procure for testing, but also to know those who turn positive from an HIV test. Then TX new is those who are newly starting ARVs, because we know the target number we want to reach on treatment, but now we need to know how many are entering that pool. And whenever a patient falls out of treatment, we need to know in the last one, TXML, why did they fall out of treatment? Did they die, or did they just disappear in the general population? So what we sought to do is to use the WHO SMART guideline approach to compute these indicators, so that any person who is going to look at our numbers can compare it using a standards-based approach to any other country that is computing their numbers using the SMART guidelines approach. For us to do this, WHO needed to provide the SMART guidelines, so that then we adapt it to Kenya's context and then implement it. So I'll talk about how this translates practically in what we had done. So this is a bit of a mapping of the L1, L2, and L3 on what we have done. So traditionally, we had the guidelines on paper form that was used to guide providers. And what we have done within the EMR, now we had the concepts that you require for you to offer services that need to be captured for you to be able to generate the indicators at the end of the day. So you have to capture a minimum data set. If you want to know someone was on treatment, you must know that they actually started treatment, they are currently taking their medication. Those are concepts that must be built in the EMR for you to be able to compute your log digit. We have been, at the point when we are operating on the paper guidelines, we were doing this manually. Now, enter Steve Wanye, enter PATH, that's IntelliSoft, PATH, WHO. They then went and looked at the WHO digital adaptation kits, and then translated the logic that we have been implementing locally into the DARC format, so that we can be able to compare it with what WHO's recommendations are. And that is what we have done. So we started off by implementing this for one indicator to prove that you can actually implement WHO SMART guidelines in an EMR in Kenya. This was very successful last year, and now we are expanding to the other indicators that I mentioned earlier. So that is work that is currently ongoing. Now, by translating our requirements documents into a digital adaptation kit, it allows you to know which variables you need to use to compute those indicators, which providers, which personas in the facility offer these services, what is the logic for computation of the indicators, what are the workflows, so that then when we come to the level 3, so basically Kenya is adapting the level 3 and level 2 and level 3 guidelines, right? So within the Kenya EMR now, doing it on a pilot basis to make sure that the computation logic is aligned with the WHO SMART guideline approach. So these are the 2 main intervention areas that this project that we are doing jointly with the other partners is doing, so that we have a set of that the team has taken is to ensure that the solutions that will be developed will be generic enough, such that any digital health solution that wants to implement it any development house that intends to implement it in their system can actually adopt it and reuse it for that particular purpose. So within Kenya EMR, we have machine learning models that are integrated to support certain decisions that healthcare workers typically make. For example, to evaluate the risk of a person turning HIV positive or a person falling out of the treatment. As we mature our systems, we hope that at some point we'll reach the point where we adopt WHO SMART guidelines for such kind of decision support features within the EMR. That is still a way off. So what are we currently doing? As I mentioned earlier, we are sensitizing the stakeholders relevant to the HIV space so that they know what SMART guidelines are. This is because governance of the clinical care processes is done through the clinical programs, and we need their buy-in for us to be able to translate their indicators into this format. Number two is just make sure that we review the indicators and ensure that we adopt them in the DAC format, standardize and map indicators in the FIRE format, and then compute them in Kenya EMR and the National Data Warehouse, so that then we can be able to document this lesson, so that anyone else who plans to adopt this approach can be able to do it in their EMR without much effort. So in terms of just what we are seeing to be what's next, basically we are starting forward with the indicators, but then we'll extend this to the clinical workflows and decision support features. We are struggling with the unstandardized requirements documentation process. We are going to be making this a bit more standardized now, moving forward, and then making sure that we don't completely rely on developer preferences in how they code and write code, so that this is guided to reduce errors in how indicators are computed and workflows are built into the system. I'll skip this slide. It's just talking about some of the benefits. I'll start on the right-hand side. Consistency in indicator computation across systems, but also across countries, so that when you're comparing country performances, you can be able to be confident that they are based on as the same standard. The second thing is just making sure that the lessons we have learned so far, because for a long time, HIV program is the one that has been digitized, we can be able to export this to other implementers so that they understand and can be able to avoid the pitfalls that we have gone through. Ensuring that accountability when you are comparing reports with other countries is maintained, and then, of course, adopting a standards-based approach for clinical decision support. And when we arrive at the level 5, making sure that machine learning assisted decision support features are also implemented as per standard. So I think this is just, this should be my last slide. For this particular project, some of the things that we are doing is making sure that we incrementally ensure that all our indicators in the HIV program are computed using the SMART guideline approach. Through this community of practice, we hope that capacity building, capacity strengthening can take place. Future versions of Kenya EMR will basically have this SMART guideline approach to indicator computation, so that then implementation can be done at scale, because that is where really you get the impact. Then availing this solution as a global good, so that any other implementers can take it and use it for their implementation. I'll stop there, because I think this is my last slide. I was presenting on behalf of Dr. Kimanga. So just to acknowledge that he has been...
Thank you, Dr. Jacob. So again, the purpose of this session is to demonstrate that Ministry of Health is already applying SMART guidelines with its partners, primarily funded by the US government through CDC. We also want to hear, and that's the HIV program. Again, this being a very new area, we can't take on a big bang approach. We have to think responsibly, learn what we are trying to do. This is people's lives, Cindy. And the systems you're building are intended to take care of people's lives, so we really can't experiment without being responsible. So therefore, the reason why the ministry is being very responsible in let's try this out first. So they're trying out with the National HIV program, and they're also trying out with the immunization program as well. So if you allow me, I'll invite Margaret to also speak about how PATH, Margaret represents PATH, are supporting Ministry of Health with support from USAID, doing the same thing, but now for the immunization program. Then I'm hoping that, or we're hoping that with these two examples in public health, that you'll all be convinced that this is not a theory. Cindy, but in the meantime, as we're setting up, are there any questions, burning questions? Or comments? Yes.
Okay, thank you for the nice presentation. I don't know whether it's me, I didn't follow the presentation. My concern is I didn't see it clearly how the SMART guideline came in, as in what was the situation before in terms of indicator reporting and after, so that we can see the effect of the SMART guideline. Thank you.
Dr. Jacob will answer those hard questions. Any other question, Dr.
Thank you. I'm not sure if this is the question for now for WHO, but I think what I am curious to understand is what the SMART guidelines look like. Is the anticipation that there is sort of a global smart guideline, and then every country has its own contextualized smart guidelines? Like, how does this actually work in terms of how we plug into a globally agreed guideline that then applies contextually to our situation and the way we manage healthcare in the different countries?
Any other question? Maybe I'll request Dr. Jacob to answer what he can, and I'll supplement.
Yeah, that is not an easy question to answer, because this work is still in pilot, so we are waiting for the results of the differences. And I think the good thing that it was happening also at the time, it is happening at the time when WHO is actually developing the WHO smart guidelines. So they are learning from our implementation context as they develop the smart guidelines. So we don't have the numbers for this meeting's purpose, but I think maybe in future ones we can actually be able to share them as part of this community of practice work. Right.
And I think for Dr. Radha's question, yeah, again, one that I would also encourage that we ask Nat as well when she comes on at 10. But right now, I think as Dr. Jacob has mentioned, the ship has sailed, and so we are building as we sail. And so there's no deviation from how this is done traditionally. It's only that now there is digital health as a new way of providing healthcare. So WHO, as a science-based organization, is being very careful not to deviate from science. So everything that is being done needs to maintain fidelity to the science. And so the way it works currently, where you've got clinical trials that generate guidelines, they are maintaining the same approach. As Dr. Jacob mentioned, the question is, with digital health, how do we improve that without violating the science? So logistically, there will be some challenges, and we're already feeling them, because then it's a very bureaucratic process where WHO develops guidelines, then member states like Kenya, like Dr. Ryan mentioned, take the guideline. We know how long domestication takes. How many of us have been part of domesticating guidelines from WHO? It takes a long time, isn't it? You know, so the question then we are grappling with, as Jacob has mentioned, is how do examples like what CDC is funding Palladium and other partners, PATH and Intellisoft to do, how does that accelerate that process? And then we feed back to WHO for them to move faster. I mean, for those of you in research, it takes, what is it, 17 years, the no-do gap. So from what we know to what we do, it takes 17 years. So one of the hypotheses is that this process will shrink that period, and we can move a lot faster from once we determine what works scientifically, how do we move that into practice? So, but again, we don't want to violate science. So that's a good question. Please ask Nat when she comes on board. Other questions? I don't know if Margaret is ready. Okay, so let's listen to Margaret, because we've got Nat coming in 20 minutes. That would be another really useful presentation. But let me welcome Margaret from PATH, and she'll talk about another application use case or case scenario of the same, but now in a different health program. This is work funded by USAID.
Thank you, Steve. I wanted to make sure I know how to use this stuff before. It's what? Oh. Yeah, so I think, and I was just whispering to Dr. Mandela, I think, you know, when you hear the WHO SMART guidelines and then you hear what Dr. Ryan was presenting, at some point it's like, okay, so are we talking about interoperability? Are we what exactly are we talking about? But I think for me, I did struggle with that question, and working with the immunization program and what I want to present today made it sound, it brought it home for me, if I can put it that way. I think all of us, you know, you knew the process. You would get a text. I think I didn't go through the process, but I'm trying to think about what my husband did. So you register, and then you get a text. You're told you can go to, for example, University of Nairobi, and you'll get your vaccine there. So if you're doing AstraZeneca or Pfizer, you know, you have a schedule for that. And that's basically how immunizations work. When we were born, we knew we get the BCG, right? And you know when you're supposed to go. Now, if you think about it from a programming point of view, if you're building a system, it can be one, then show BCG immunization to be given. So then by day 5, make it red because it's due, right? You're already past the due date. With the WHO SMART guidelines, it was so easy to do this because those simple guidelines, simple in terms of if else and looking at the age, are very simple, it's a simple implementation guide that you put in, and I want to show it so that I stop rambling. But the Kenya National Immunization Policy Guideline 2023 is what we used for this work. So basically, everything you know about your child from when they're born to when they're 5 years is actually put in a simple digital adaptation kit. It's very simple, as in because we know age 0 is BCG and OPV. You write it down there, and I wish I could show that as an Excel sheet and on the implementation guide, but I just like to. I thought that would help bring it home. So we have the National Immunization Policy Guideline 2023, and then we have what is known. That is what we put together and developed a digital adaptation kit. Very simple kit, which brings all these things together in one document. That's what I'm trying to bring out. I don't know if it is coming out clearly. In Kenya, we have the mother-child baby booklet, which for me as a mother, I walk around with. I have it at home, and then when I'm going to the hospital, I also carry it. It has a schedule, right? It says, now your baby is 6 weeks, they need to get 1, 2, 3 immunization. So when I go, they give that to me, to my child, and then they write the immunization that was given, right? But at the hospital, something has to remain. So these other things remain. The health facility register, there's another form that they use again for tallying what the children have been given. For yellow fever, we all have this as well. And then all these other 2 things, like for managing of the product, the health products for immunization, which the Chanjo LMIS again handles. So all these things basically is what we are trying to digitize. And how is it possible? It's only through using the SMART guidelines, which I think I'll talk about in a few. I like to mention this because childhood vaccination has been recognized as the greatest medical success story of the 20th century. Many of the diseases that are being eradicated are eradicated through using complete vaccination. And that's what we are trying to do here. We're saying if we can get to a place where we provide individual level data for the government towards about immunization, so that they can say, we have, for example, 10 children who have been immunized at Magadi. 8 of them were immunized on day 1 at birth. 2 of them were immunized when they were 1 year. We can start asking, we are trying to have 0-dosed children. We'll try to eliminate 0-dose children. Why are we having a child who's being immunized at 1 year? What is the issue? Immunized for BCG at 1 year. And then we can have targeted responses through the immunization program. So what we are doing is strengthening immunization through the system. So ensuring there is data exchange and timely immunization reporting. Having consolidated immunization histories, I think what I've just tried to present. And at population level, we have numbers, but they have a story behind the numbers. As much as possible, I think that's what we are looking to do. So the rationale is here, and I think I have explained this. So I want to jump when I was starting for the COVID that we did. So we thought, considering how well Chanjo KE has been scaled out, and I think everybody in Kenya was able to access this system, we thought we could leverage the system to now have routine immunization as part of the system. And that's what we did. So we went through the Kenya National Guidelines for Immunization 2023, developed the digital adaptation kit based on the immunization schedules, what I was talking about, the OPVs, the diphtheria and all that. Very simple document that says at this age you do this, and then after that we develop the if-else statements, which again are level, I believe that's level that we develop the fire open change have been verified and endorsed by developed and is based on fire. And again, this will be in line with the Kenya Digital Health Superhighway, as Dr. Ryan discussed, because it will be able to consume, for example, the terminology services, because it is based on a standard-based approach. It is developed on a standard-based approach. I wanted to, now it's not working. I wanted to show one slide of how the app looks like, but this thing is not moving. I'm not sure what I'm doing wrong. Oh, yeah, I think I talked about this. The only thing I might not have mentioned is the generation of the WHO digital COVID certificates, which again is in compliance with the WHO standards. And based on the fact that we're using the WHO smart guidelines, it was very easy then to come up with this certificate, so that wherever you go with your COVID certificate, and at that time it was very critical, you can always show your certificate, you can show a QR code and scan, and it is, you're certified as having vaccinated, having been vaccinated. I don't know if I want to go through this, but let me just show this. So this is what I meant. So as long as you have the implementation guide described well, you put the implementation guide into the Fire app, the schedule then just is presented to you. So the healthcare worker, on receiving a baby, registering the baby, and the date of birth says, for example, in this case, the baby was 2 days, it already shows you the schedule for the child. If the baby comes at 6 months, they've gotten all these other vaccines, you'll be shown the schedule of the ones that you've already received and the ones that are due. And it's very simple to do it. I keep saying that, then I think I wish I could show more. Yeah, it has refused again. This is the last slide. Yeah, just to show how, and then once the vaccine is administered, as you can see the details of the same. And again, this is for everything up to 5 years. And just to mention, the guideline also caters for special groups, so tetanus for pregnant women, preventive vaccines for example, healthcare workers, and things like, I think there's another one I'm forgetting. There are 3 special groups. I've forgotten the last one. But all that have been put in the schedules. And so the app just consumes those schedules and presents them to the healthcare worker. I hope that was helpful.
Let's give a hand of applause. All right. I imagine at this point you're either extremely confused, or it's very clear, isn't it? Or you're somewhere in between, right? I'm sure we've probably had many new words and terminologies used for the first time. DACs, digital adaptation kits, L1, L2, L3, L4, L5, and all that. So please bear with us. One, I must apologize that we are not following the program. And that's just because of scheduling challenges. But all this will be brought together in 10 minutes when we hear from WHO. But if are there any questions right now? So we can do 1 or 2 things. Take a bunch of questions if there are any very burning questions. Also, there's still breakfast. So we can also take a short health break. We've been sitting for 2 hours plus. As we wait for the WHO session that's starting at 10, that will bring together all these things, all the concepts where you have questions, where you need clarification, your question was not fully answered. That's the time to ask. Are there any burning questions? But also, let's take a break. 10 minutes to listen to the WHO presentation. Hi, Nat. If you can hear us, please go ahead. Floor is yours. And I think you're on mute. Sorry, just 1 second, Nat. They're trying to fix your mic so we can hear you. You can try now, Nat. Sorry, Nat, we cannot hear you. They're trying to fix your mic. So just 1 second. Yeah, we could hear you.
Okay, great, thank you.
Rather than provision of care. And so, of course, with the opportunities of using digital technologies, we want to move to something that allows for greater fidelity and uptake of evidence-based guidelines to ensure that there's high quality care. Of course, ensuring there's interoperable systems so that all the data that the health worker is inputting into the system is actually usable. And of course, reducing the costs and time required to develop and adopt digital solutions, because we all know that digital can get very expensive very fast, and also support local production of technology so that there's greater sustainability in countries for all of these digital health solutions. And then, of course, supporting the health worker and having a human-centered design-based approach where we want to support the health worker in their day-to-day and ensuring that they're only collecting data once and you're able to then use that many times, and focusing on having the ability to have secondary data use rather than really deploying solutions for simple reporting. And of course, with all of these digital solutions in place and digitized health information, we do hope that there's a future where individuals will have greater access and control over their own health data. And so before going into specifically what the SMART guidelines are, and I think many of you already know this already as well, but just to highlight that the SMART guidelines are really intended to intervene at key points of the software development lifecycle. And so for those of you who might not be as familiar with this, of course, there's the gathering user requirement stage, so understanding what you're building a digital solution for, designing an adaptation based on those requirements, so that's doing the actual coding. And you have to train, test the solution, and then roll it out. And then, of course, as you scale, you gather feedback. And then there's a continuous, for those who aren't familiar, is really common for across all digital technologies. So it's not unique to digital health in any way. But for the SMART guidance work, we really are intending to intervene at the gather user requirement stage, as well as the design adaptation development stage, to ensure that we can move from proprietary monolithic systems to Lego's building block-based system, so that we can provide standardized base app logic, provide a standardized data model based on the HL7 FHIR standard, and that local technology teams can really focus on the actual user-centered design aspect of it and focus on the UI, the UX, content adaptation that's unique to the country, and really having something that's a bit more agile and scalable, rather than having proprietary systems built for each use case. And just to highlight too, when I say proprietary, I don't necessarily mean that it's not open source, because open source solutions can also still have their own unique data models that are not usable. And I think that's what has led to the lack of interoperability across existing systems right now. And so the Smart Guidelines Framework is really an approach that WHO is taking to provide WHO recommendations in a way that is more useful to the digital health community and to the technology partners that are intended to adopt the guidelines. Again, many of you have probably seen this already as well, but I do want to just quickly go over it in a sense where there's 5 key layers. So first is the narrative layer, where we have the PDF recommendation documents. I think this is where a lot of the health program leads in countries will be very familiar with the WHO publications. We do publish a lot of guidelines. And so we do hope that a future where we're working with the Quality Norms and Standards Department, where we're actually making these narrative guidelines also more precise and operational in a narrative format, because then that will allow for easier adoption into the digital space. And so the layer 2 of this framework is the digital adaptation kit. So this is essentially the requirements documentation. It can be used as a starting point essentially, or starter kit, so to speak, for countries to then be able to gather their own requirements, but instead of having to redraw workflows, for example, you can start adapting from existing guidelines and then leverage the data dictionary as well as the decision support logic to have, sorry, I'm seeing that YouTube feed has an echo. I'm not sure how to address that, but I'll just keep going. Sorry. And so having the digital adaptation kits be that starting point for a requirements document. And then from there, we have the machine-readable guidelines, which is the FHIR implementation guide. So this is the machine-readable components that is in software code. This is where it would be useful in the development and adaptation stage, where software developers are actually coding the solution and leveraging these interoperability standards. And these machine-readable guidelines are a representation of the digital adaptation kits, but in the interoperable standards format. And then we have the executable format, which are essentially reference software. I think generally speaking, we would have components of this that are directly from the L3, but then of course, as you'll know, in order to translate the machine-readable guidelines, there is quite a bit of components of the executable components that we provide to support countries to then adopt that reference software for their own systems. And to clarify, the executable guidelines are not something you can just download from the App Store. It is a repository on GitHub, but then it's something that software developers can still work off of. And then of course, as we see a future where we have a lot of AI usage, we do hope that we can work towards having dynamic guidelines. So having things that are more focused on precision public health or precision health, and being able to leverage advanced analytics based on all the data that has been collected directly in countries in a standardized format to really inform AI-based decision support, but then also inform the development of the guidelines themselves. So really, this is more of a loop rather than a stepwise framework. And so like all WHO guidelines, each component of the SMART guidelines are intended to be adapted by countries. So of course, as WHO has narrative guidelines that are published, currently countries do go through a process of adapting their national policies in order to be updated to meet the latest evidence base. But then, of course, there's other considerations like health financing that has to come into place when it comes to policy decisions. But of course, that also then needs to be translated across all the layers as well. And so each of these layers are intended to be adaptable. They're built in that way so that they're digital health. Just to highlight that the SMART guidelines, when you see them, they are intended to be adapted. So of course, there's going to be certain things that you see that might not be relevant for Kenya, but that's intended because the guidelines, the SMART guidelines are intended to represent a global guideline. And so of course, there needs to be a certain level of adaptation to that as well. And also, I think another important point to highlight is that as countries are at different points in their digital health maturity, each of the SMART guidelines really is intended to have their own benefits. So you don't have to start at L2 and then go through L3 and L4, for example. If, say, a country already has a very robust policy-making mechanism that includes digital considerations and already has a robust requirements gathering process, perhaps you do just use the FHIR implementation guide for interoperability. But maybe just to highlight that is that for the narrative layer, of course, this is a prerequisite. So I would say that each digital deployment would require some sort of policy change or at least policy alignment if it's not already there, because we want to that. So I think that that's important, and bridging language that can help update paper systems as well. And I think we've had a lot of feedback around, oh, why not we just jump from the L1 narrative to, say, the dynamic, because we have Gen AI, there's a lot of work on that already and excitement around that. I think the issue of having a black box solution doesn't go away if you go that approach. I think we found that a lot of countries have been deploying digital technologies without actually knowing what data has gone into it, because they have gone through that collective requirements. Digital adaptation kits provide that framework and methodology to allow for that shared documentation to be understood across all states, allowing you to be more confident in the fidelity of the conclusions for algorithms that are there. Because again, it provides that transparency, but now it's just simply just having more sophisticated systems. And I think to take a step back too is that, of course, we're talking specifically about the SMART guidelines, but when we do go to implement the SMART guidelines, it's important to understand that this is just one piece of the entire puzzle. So the SMART guidelines are intended to provide the health content requirements. But if you're familiar with assess an enabling environment, understanding the landscape, having a shared vision and future state architecture and so forth, before the SMART guidelines kind of really come into fit into that piece of the puzzle. So just to highlight that before you go into kind of just implementing SMART guidelines, it would be important to understand the overall context of the digital health space within the country and having a shared strategic vision in which SMART guidelines could fit. But we do have the antenatal care publish, the COVID certificates published, the family planning, SMART guidelines published, the HIV. I think, sorry, this slide's a bit out of date. That's also been published. The tuberculosis and child health in emergency settings, that is also to focus on as well. A lot of these, quite frankly, are just funding dependent. And so we've been a bit opportunistic in leveraging funding where we can to support this. But we haven't been able to move all of WHO guidelines to SMART guidance just yet. And I know that countries like Kenya, for example, are very keen to adopt this process and all the SMART guidance that we have available, but we don't have all the SMART guidance available yet for primary healthcare. And so I would say that for countries that are intending to do that, we do have their own SMART guideline for, I don't know, for NCDs, for example, that we haven't really started yet. And adhering to best practice, but not necessarily having to go wait for WHO to publish SMART guidelines, because I would imagine the L1, for example, for a certain, and I think so as we are seeing health worker tools adopting the FHIR. the individual record across, so that allows for the health record to follow.
Hi, Nat. Sorry, we lost you for a minute, so you may have to go back one slide. Yeah. Sorry.
What's happening? Should they stop or?
Sorry.
Keep going.
The network went out, so.
I guess I'll keep going if I don't hear anything. Okay.
Can you hear
no,
me?
so I just want to say it's really exciting to see Kenya have its own community of practice growing. Of course, you go back one slide. Okay. Should I re-present this slide, or was there a question? Oh. Is it this slide?
No, we can't even see your slide.
Okay. Should I just re-present the slide then?
Yes.
Oh, reshare again. Okay. Is this good to go? Great. Okay. So I'll just start over, and apologies for that. So the current status of smart guidance development, as you can see, we have a long list of things that have been developed already. So we have the antenatal care, family planning, COVID certificates, HIV that has already been published. The tuberculosis and child health and emergency settings, that will be published within the coming weeks, essentially. But of course, we have things like immunizations, postnatal care that are also in the final stages. But of course, we haven't got all the areas of primary healthcare yet. That's where we hope to go, is to have all WHO guidelines in primary healthcare in a smart format. But if we're done, and quite frankly, a lot of the constraints here are around funding. So we've been a bit opportunistic around that. But I think for countries such as Kenya that are keen to move ahead and not necessarily wait for WHO to publish all the guidelines in a smart format, we do have templates and standard operating procedures that can be shared with you, so that you can still follow the smart guidance methodology and have that best practice in terms of documentation without necessarily having to wait for WHO to publish a smart guideline. Because of course, I would imagine in an area, say NCDs, if that's a priority for Kenya, there must already be an L1, so to speak, within Kenya around NCDs, and with and I think the greater picture in all this is that a lot of these smart guides so far have been focused on the health worker, so the provider side. For providers, we do hope that there's a future where we can then generate patient summaries or individual health records from the provider side application into a personal health record that individuals can hold. So this would be things like a home-based record, the maternal child health card, immunization certificates, patient summaries, and so forth, that can then be held by the individual wherever they go, but then also verified so that they can actually use it. And so the verification piece comes in with the Global Digital Health Certification Network. If you've heard of that, we've deployed that for the COVID certificates, vaccination prophylaxis, and of course, a patient summary where if someone travels from one country to another and there's a health incident, they're still able to get the appropriate care. And so I do want to say it's very exciting to see a community of practice growing in Kenya. Of course, we've had a huge community of practice that's been growing slowly over the years globally. And so there's been the hackathon in Kigali, which is a number of that the AHIN General meet updates from Kenya on a weekly basis. And then we have the Connectathon in Sao Paulo for Brazil, for the International Patient Summary work and the Global Digital Certification Network. And so, of course, it's great to see that there's a specific Kenya-focused community practice, but I do want to encourage you to also participate in the global gatherings as well. And here's just kind of a list of partners that have been participating more regularly. This is by no means complete. There's been a lot more partners. there's of course the Monday calls. They previously used to be Monday and Tuesday, so for those of you on the call, reach out to us at who.in because the calls now have been combined for authoring and implementing on Mondays at 2 p.m. too, so I think Kenya time. And then we have first call that's focused on the Android Fire.
Recording in progress.
Fire@google.com. And then for those who are even more, oh, lost you again. Should I still stay on the slide and restart, or should I keep going? Okay, I'll stay on the slide and restart. Okay, so what I was saying is that it's very exciting to see like a community of practice growing in Kenya, but of course, we hope that you can participate in the global community as well. There's been a lot of partners that have been involved, and this list is by no means complete. So now we have an authoring and implementers call that have been combined, and it's every Monday at 2 p.m. GMT, so that's around 4 p.m. Kenya time. For those of you who might have lost an invite, if you were, because there used to be 2 calls Monday and Tuesdays, please just let us know at smart@who.in, and we'd be happy to share the Monday calls with you as well. And this is really just a weekly working group call to touch base on everyone who's been authoring or implementing SMART guidelines. So it would be great to hear back from the group in the community in Kenya as well. There's also the developers call that's focused on the Android Fire SDK, or the Fire Software Development Kit. And that call is being led by Google. So if anyone's a developer who's interested in understanding how to use Fire natively on Android, please do join that call and reach out to androidfire@google.com. And for those of you who are more interested in the HL7 Fire community, that is on the Zoom chat. So it's a big chat that everyone within the Fire community uses, but of course there's specific channels related to SMART guidelines as well. And that's also an area where you could reach a lot of Fire experts that maybe don't join the calls regularly. So people like Graham Grieve or Bryn or others who are really Fire experts, but they go beyond just the SMART guidance work. And so that's a great place to also expand the community to beyond just SMART guidelines, but really focusing on the Fire side of things. So with that, thank you. Apologies for all the technical issues, but I'm happy to answer any questions you may have.
Thanks, Nat. Do you have any burning questions for Nat? I recognize you only have 30 minutes to go, so be respectful for everyone's time.
Yeah, thank you, Nat, for the beautiful presentation. I think it's very timely. My interest is the point where we are translating the standards or the guidelines into the digital toolkits. What does that process look like? Are there standard templates that countries will use to do that? Or is that something that WHO team will build the capacity for countries to be able to do it? And more so when we know that there's so many standards that are out there. As you've mentioned in, I think in your second last slide, many of them haven't been published yet. So what is that process going to look like? And when countries become innovative and they're able to translate these guidelines into executable formats that can be used in the different digital solutions, is there a place where this is published or hosted so that people can reuse and can also learn from other countries? Thank you.
Thank you. Nat, I'm going to try and take 2 more questions for you. Other questions? Any other question for WHO? Mandela?
I think this is in line with the same question. I know LLMs have this black box effect that can prevent the use case, especially on the transparency and explainability bit, but is there a use case for at least tokenization of these narrative guidelines so that we can at least adapt them in the dark format as a use case to begin with?
Any other question? All right, Nat, I hope you got the questions. Please go ahead. You checking with the other sheet? Okay. As you wait, any other questions? As you wait, any other question? Any other?
Documents essentially a requirements gathering document. And so there would be a lot of kind of understanding what the clinical decision is and trying to outline what that is. And so we'd be happy to share the templates and SOPs for that. Similarly, for the L3, there is a process for that. That requires a lot more technical development, so software development, and some understanding of the HL7 fire standard. But again, that is actually already available on GitHub, so happy to share that. And in terms of a place to share what the best governance and best place would be for other countries to share, because there's certain limitations in terms of what WHO can host, essentially. And it is a bit frustrating in that sense, but I think we hope to leverage our partnerships with yourselves and others to see if there could be a place where you could share smart guidelines more broadly in a central place. And in terms of the questions around the use of LLMs and adapting the smart guidelines or creating the smart guidelines, we are currently exploring what and where LLMs can be used and how best they can be used. So far, they haven't been that helpful. I think we have tried to see, for example, if we could take a narrative text and turn that into a BPMN-based workflow. It hasn't turned out exactly well, but we are exploring to see, for example, if we could translate the decision support logic into CQL statements. But again, it hasn't turned out well yet, but I do think that's certainly a place where there's a lot of potential. Any other questions?
Thanks, Nat. I think we have time for maybe two more questions. Any burning questions for Nat? But I think generally, some of the questions that were asked earlier, Nat, you've actually answered them. One of that I think was.
Hear the room, so.
Okay, I don't know that she can hear me or not. But are there other questions for her before we let her go? All right. If there are any other questions that can't be answered right now, we can always follow up with her later. So I don't know who's communicating with her. You can let her know that we're thankful for her time. Yeah, but I think the other question that was asked earlier about the process for creating smart guidelines, I hope that was answered by Nat. That was asked by a few people, that Kenya doesn't need to wait for WHO to publish. We can use their methodologies, their approaches, and their templates, which are available, as was presented by MOH partners who are already supporting HIV and immunization, using those methodologies and approaches and templates, and we can share those through this community. So there's a lot that I think most of us are familiar with, and we're happy to share. And then where we run into challenges, we can obviously work with WHO to get guidance. Great. So I think in the remaining. Okay, Nat, if you can hear us, there's one question on chat. If you want to answer that. Nat, are you able to answer the question on chat? Apparently, it's an important question. We've got about 20 minutes. To provide a vote of thanks from Ministry.
Hi, Nat. Good to see you again. Thank you very much for taking your time. I hope everyone in the room has at least a bit better understanding of what the process of getting the MY guidelines are, how much work is there, but also more importantly to see the type of support that is there for this type of work and why it's important to do that. For that, I want to thank you for your time. I think from the talk today, what we'll do is we'll formalize a bit more our participation on the calls. We'll form a team from MOH who will nominate to be attending the calls so that we can have coordination from our side. But thank you very much for your time, and thank you very much for everyone for listening to that. Thanks, Steve.
All right. I think in this last couple of minutes, before I invite Dr. Langat to close the meeting for us, I just want to summarize a few things today, and if there's any ambiguity, I think let's try and get some alignment. So just to go back to why did we come here today? So this is the first of many meetings for this Smart Guidelines Community of Practice for Kenya. I think just for you to know, Kenya is the first country that is establishing a community of practice around Smart Guidelines. As you heard from Nelly earlier, Helena, which is the Pan-African Health Informatics Association, which I represent currently as the president, is coordinating this across the continent with WHO. So Helena is, and you can check out helena.africa if you're interested. But Helena is the Secretariat for Smart Guidelines in Africa, working closely with the WHO, which means that we are coordinating across multiple countries, of course working very closely with WHO Afro and Africa CDC as the other two continental bodies to coordinate smart guideline adoption and adaptation in African countries. And Kenya, like always, we are always first off the block. We're the ones first off the block in terms of creating this community. So give yourselves a round of applause being the first members of this community. So this is a model we want to replicate across other countries, at least at the Helena and Africa CDC and WHO Afro level, working with the other partners and also WHO headquarters as well. So the idea, again, going back to why we came here today, is to want to start collaborating better and in a more structured way. So we need a secretariat. Of course, this work is led by Ministry of Health, but MOH, as always, government broadly has always been working in partnerships with everyone else. And so even for this initiative, and hence the reason why we have Dr. Langat here, is so that we can do this more efficiently, collaboratively, all of us together. And community is the best platform that has been identified to get this kind of work done. I think most of us are members of open source communities, so there's no difference here. It's really that openness. Let's share, all these are public goods, open source licenses. So it's available, as Nat mentioned, and we'll make sure all that is available broadly to everyone. Dr. Langat will talk about the Digital Health Agency that will additionally provide the governance required. All this work requires governance, requires leadership, and ministry has been doing this for a long time, hence the reason why they also saw it fit to create an agency. So whatever will be created will be publicly shareable, but it needs to be governed so that it's efficient and it's actually usable. So ministry intends through the agency to manage these resources so that everyone can use them. We do it once, as Nat mentioned. We do it once and it's reusable multiple times by all of us and by the entire health sector. So that's the whole idea around this. So as we get this set up, in the meantime, Kay here, represented by Dr. Sylvia at the back, will act as a secretariat. Kay here, like I mentioned earlier, Kenya Health Informatics Association. It's a neutral body And the idea behind Care Here is to promote the profession of digital health. Care Here is not promoting any organizational ideals. So I know each one of us here represents an organization, but we also acknowledged earlier that each one of us is a professional by your own right. We keep moving jobs, isn't it? We keep moving affiliation, but you don't stop being who you are as a professional. So the question is, as professionals, do we have a platform where we can associate? Yes, we do, and that's Care Here. So Care Here is intended deliberately to be neutral. It doesn't promote a specific ideal by a specific organization. It's supposed to represent the profession. Just like if you're an engineer, if you're a lawyer, if you're a medical doctor, you've got your own professional association that promotes your profession. That's the whole idea about Care Here. So in that respect, Care Here will, in the meantime, as everything is getting set up, support this as a secretariat to make sure that we're actually efficient. And so Sylvia, if everyone is okay, and please you can let Sylvia know, we'll share a lot of information about how do we make this more efficient and ensure that everyone participates effectively. Like I mentioned earlier, there are a couple of activities that are being planned from here henceforth. We're planning to have connectathons, again co-hosted with the Ministry of Health and Digital Health Agency, to ensure that on the interoperability component, especially if you're working in L3 upwards, that your systems are interoperable based on the smart guideline approach. So again, all that will be communicated. Some of you have been part of connectathons in the past, and these are specifically FHIR connectathons. FHIR, if you're unclear, please check it out, because there are different types of connectathons. And that's the reason is because MOH has selected FHIR as the base standard for interoperability. So, and again, as you heard from Nat, smart guidelines are implemented from L3 going upwards, mainly through FHIR, but that's not the only standard that is used. The others as well, including clinical quality language, CQL, and others. The other one is mentioned earlier by Dr. Ryan. Ministry has prioritized some use cases for this investment, and one of those is electronic claims and continuity of care. So the patient summary component, there's a standard called IPS, International Patient Summary, that is part of the SMART guideline work, will also be implemented, and is actually being implemented already. So there's quite a lot of deep technical stuff that is going on by the ministry, and we'll communicate all that and ensure that there is an effective way for everyone to participate in. So please expect to hear from Sylvia about, so we'll provide all these slides to everyone. We'll provide clear summaries of next steps and activities being planned. So Connectathon is one that we're really looking forward to. And then, like I mentioned, we are hoping in conjunction with, Ministry of Health and the Digital Health Agency is hosting the Global Digital Health Forum. It's a really, really important conference. It's the main conference for digital health in the world. Happens once a year. Again, like I mentioned earlier, it's always been taking place in Washington, D.C. And for the first time, Kenya is hosting it. So I think it's testimony for the leadership being provided by this administration and the interest that the government has expressed in investing in digital health. Because it's a very, it took a lot of intervention lobbying by the government to actually convince the organizers to bring that meeting to Kenya. For the last 10 plus years, it's always been held in the US, and it took a lot of lobbying. So that shows the commitment of the government and the Office of the President to do that. So that's an important, everyone will be coming here. So we've got a lot to showcase, we've got a lot to learn as well and share with the rest of the world. So with those few remarks, please allow me, so that I know everyone is really busy, really thankful for your time, but please allow me to welcome Dr. Langat to give us his remarks and close the meeting for us. Thank you very much.
Well, thank you, Steve, and good morning. And apologies also I was here early in the morning, but I had to do a virtual meeting. At least government, we are now embracing digitization, so in some instances I would have gone to Afia House to have a meeting with my DDG. But I managed to catch a few things. I think I came in when the colleague from WHO was presenting, but I'm sure I can see a lot of representation from my directorate. And I also want to appreciate, I mean, to host such a meeting here, and after this hour we still have people listening and participating, and I think is key. And I've always told my staff that it's amazing, you know, I work in tuberculosis space, a lot of commitment there also. So when I came to digital health, you know, the kind of output, the commitment that I'm seeing is really, and we are already making waves globally. And I really want to appreciate the support that I've had from all the partners. When we called you and we told you that this is our thinking for the ministry, that we are coming to you so that we agree on a vision. We are not coming to you to tell you this is how you want to go. And we all have agreed actually on the Kenya Digital Health Superhighway vision. I'm sure Ryan mentioned that. And the government has already shown commitment. That is not just a vision, it's not a dream. I'm sure Ryan, all of you testify to these colleagues that we are already in a procurement process to set up the HIE. We are already, that means all the registries that you require and adoption of some of the guidelines that we are discussing here. So we believe by July, some of the providers that are already digitized will already start consuming the HIE, the National Health Information Exchange Platform. And I'm sure you also mentioned that linked to that is also the question of claims, that the shift from the social health authorities that we digitize and automate the process as much as possible. So that is something that is also kicking in 1st of July. And we're also trying to assist the providers that you don't move from digital, then if you want to report to KHIS, you have again to go and do it manually. So to automate some of those processes. So we want to facilitate you and support you so that if you are digital, then your reporting also become fully automated. And that is the promise of the government, and the timelines are very tight. I think we have been told that we need to be realistic. So we do understand that maybe 1st of July, probably those with good systems. Remember, you need to be certified. You also mentioned that. So there's a certification of your system so that you can be connected to the interoperability or the HIE. But we are hopeful from the survey that we did that almost 39% of our facilities to a certain extent have a digital solution. So we're hopeful that we can start from that note, that we can link those ones in another 2-3 months. Then we need to address the question of what happens to level 2s and level 3s that are virtually and probably don't even have the hope that they will be digitized. The government is committing to provide the catches and the applications, but it will take a bit of time. So we'll, at some point, of course, probably be having an hybrid, and then within probably 2 years, everyone should be paperless. Yeah, and yeah, that really is our ambition. Yeah, I'm happy with the community of practice. I think when we, out of the convergent meetings, I think we really developed quite a number of technical working groups. So for these smart guidelines, I think the idea for government is that let it feed back to existing structures. So we have got the ICCs and technical working groups. Sometimes we also call them community of practice. So let's make sure that the structure is there. Because if you want your resolutions as a community of practice to be adopted, then it has to come to ICC. I co-chair the ICC with the CC for Kisumu. So I think it's really important that we make sure that we build into that. So whatever community of practice you are doing or you are supporting, let it feed back to existing structures. We are also doing that in other places. The clinical trials the other day, it's a big investment opportunity for this country. We know that a lot of money in clinical trials, so we are also supporting them. Part of our mandate is research. Now, Steve mentioned that, yeah, let me mention about the public goods. Even as we build our digital infrastructure or digital ecosystem, as a government, we are recognizing the need to use most of the public goods. Yeah, so that is a commitment we can assure you that wherever possible, if there's a public good, then we'll utilize it. If not, then even as we acquire it, we have to see how best we can we can gain ownership and avail to the public. I think Steve, you mentioned, so that I really don't make a long speech, the role of the digital agency. Yes, the law created, you know, it was assented in last year by the President, 19th of October. And it has taken a bit of time, but we now have a fully constituted digital board chair with a chair, representation from the private sector, and the counties actually to have almost 3 slots there. We tentatively have a, we'll confirm, but we have an acting CEO, subject to the normal bureaucratic process, but there will be already, we have identified one. And the directorate will supposed to support the digital agency. So those are things we'll have to work out on. We'll move, and because the idea, whatever we are saying, we are setting up and procuring, the person to manage is the agency, not the ministry. So most of the systems that we are used to now, remember, is the agency who is going to manage, whether it's the HIE, whether it's the e-claims, KHIS, even some of the applications that are running and in the vertical programs, they'll most be shifted to the agency. Because we know the agency, the reason why we created the agency is we wanted it to have the right structures, the right human resources. They also generate money, and we think that with that, they can actually build us, they can support the maintenance, the upgrades that is required. So that agency is now fully constituted. They actually, we have originated the board the last 2 weeks, and we have taken them through the regulations. So that is one other bit you need to know, that the act just is a framework or a guide, but the how and the what will have to come in the regulations. So we'll be publishing regulations soon for public participation. We are at the moment engaging with COG. The law says that the CS in consultation with the county. So we are consulting, and we are in agreement, and just gone through. There will be 3 regulations actually, not one. One to do with the system, another to do about the data management, and the data management and the exchange. So those are the 3 regulations. We have already done a regulatory impact assessment, and that will be published, hopefully. So we also want you to look at it when it comes to, you most likely going to see it in the parliamentary website, but also avail, because for every regulation you do, we need to know what is the implication, both economically, socially, and those are things that you'll be seeing coming. We want to encourage you to contribute to those regulations. Those regulations is telling you, we say we want to certify your system. So there'll be an element of the process, there's an element of the requirements, but there's also an element that it costs money to certify an application. We are asking you to connect to the enterprise service bus. That's what we are calling the HIE. It costs money to connect. Yes, we can, and to maintain you, to make sure that you are safe to everyone who is in that bus. So you take note of that. There are applications also that is expected if you are a data controller. Remember, the agency will maintain the shareable health record and whatnot, but the completeness and the authenticity of what you share is coming from you as a data controller, as a hospital, as a county, for those who manage counties. So you may also be seeing some contracts that will be issued so that we protect you and you also protect ourselves from whatever you share. Yeah. So I think is quite, so we are not dreaming fully. For those who are in, they've always, actually every time we talk to people, some are thinking it is something that will take 2 years. It will take another 1 year. The truth is that we actually we have started moving some of those. In fact, we are very late. There's a demand that we need to move quickly. Yeah, but also literacy, we really need to move out of our space and start speaking to healthcare workers. Remember, the success of any application you deploy is the person seeing the patient and the communities. So we are also working on a communication plan with some of our partners. We may reach out to you if you think you want to contribute to that, but we really need to have a comprehensive communication plan targeting all the stakeholders. And I keep on saying the most important person is that patient. What you are promising a patient is patient data portability. That everywhere you go, whichever hospital you go, you will have a longitudinal record of your engagement and encounters in whatever hospital you go to. And they need to demand that, they need to understand what it means for their care. It is something we are promising to the providers. So I'm hopeful that when we reach out to you, you'll support us. Is really, we need massive. I've just seen, even for the people who are fairly, I think my colleague the other day presented to Association of Pediatricians, and somehow they feel like we are pushing them, because so we'll try and do that bit of now aggressively communicate and mobilize our population so that they can adopt our solutions. Yeah, and maybe just as I close, to reiterate that we committed that we supported Global Digital Health Forum, because I think Steve has always mentioned to us that you guys, you don't appreciate what Kenya has done in 1 year. But we appreciate that is a recognition as a country, and it's the effort of all of us, by the way. I think as a government, we just gave you the space, the opportunity to work with us. And let's also see how we can showcase Kenya in December. And we also promise that we'll get the necessary leadership to patronize that event, so that we get the global. We at least we show the commitment of the government. So our president is one of our biggest ambassadors. So I keep on encouraging ourselves that let's maximize it. You rarely get those opportunities. So if the speed that we are moving sounds a bit societal, just work with us. Because I think, just work with us. At some point we'll explain why something did not happen. But we can never go back to our leaders and say it is impossible, it cannot be done in 2 years, it cannot be done in 6 months. Bear with us. We also know the reality, but we just have to start the job and we complete it. Whether it takes 1 year, it takes 2 years. But the key thing is that we are all committed and we do what it takes to get what is possible to be done in whatever timelines that we have agreed. So please receive any apologies for having made a very long speech, but just to let you know, as a government, there is an absolute commitment. We are open and we are willing, but we also, once we say this is the direction, tomorrow don't come and say, we'll also make sure that we whip you to that direction. Because that law is actually, we hope that it can bring sanity in this space. Every time we speak to counties, they are saying we needed this, like yesterday, if we are certifying systems, if we know what to buy, if they are willing to walk that journey, but it will cost money. I know the biggest problem is the revenue, but if we want to sustain digital health ecosystem, we cannot be relying on donors. We know that we can generate money to pay for this. So I want you to be the ambassadors, especially for revenue generation. One of the proposals you'll be hearing is, for every claim you make, you give us a certain fraction of that. Yes. Because by the time you are raising an e-claim, you are the source of reference for your client. Just let's start from there. Your client just comes with an ID and you're able to get the records. We are giving you as a source of reference that the provider who is in that ecosystem is licensed by a regulator because you are interoperating with the regulator. They are maintaining a true record of the patient as an independent mediator. We are not a provider, so we don't offer services. We are not an insurance guy who is making sure that by the time he's paying you, he has reduced the pay to what he thinks he can afford. You want to maximize, the other guy want to minimize. We are the mediator. So when we come and ask you for a small fraction of your claim, it's because there's a reason we want to reinvest that. Yeah. For the private sector, the government is saying even if you are a small clinic, you don't need to go buy an application. We can give you at no cost. So it is not about government, it's about everyone. So we really want this, as the people understand digital health, I want you to be the ambassadors to say it is not cheap, it is going to cost money. Yeah? But then what you should be asking is accountability of that money. What is that money to this space? If we don't agree on that, then we'll have an ecosystem that will be reliant on outsiders. We think we can generate enough revenue to support you. So thank you and enjoy your remaining part of the day, and all the best to the community of health practice.
Thank you very much, Dr. Langat. I have nothing else to add, just to thank everyone for coming. I know it's a few minutes after 11, and just to respect each one's time, I really thank you very much. Kindly, if you haven't registered, please check in with Sylvia at the back, or there's a paper at your desk that you can scan to leave your details. But we'll definitely follow up with you. Thank you, everyone, and have a good day ahead. I think there's still some breakfast for those of you who haven't had. Thank you very much.
Please have a group photo before everyone goes. We can, I guess, oh yeah, at the staircase, please. Thanks.
When I in the office, we have so many false starts with my son.
Please, let's take a photo. I'm told we need to take a photo, evidence that just at the staircase, outside. I'll start moving everyone outside. Let's go out and take a photo. Sorry for inconveniencing you, but let's take a photo. At the staircase, just outside on the left. Outside through the main door on the left. 20, gentlemen. Let's take a photo outside. Peter, 20.